session is designed to answer, just go over a brief overview of in vitro fertilization or IVF, and then answer any questions that you may have about the process, things that come up through the session, things that you've been wondering, whether you're about to start an IVF cycle, have done an IVF cycle before, you're about to start your fertility journey and just want to know more about IVF. All good places to be to learn from this information. So here is the fertility team from RMA of Michigan. Going from left to right, this is myself, Dr. Karen Wheeler. In the middle, Dr. Brad Miller, and on the right, Dr. Linda Wolf. And so the way that we organize the office is that every patient has a primary physician, and the primary physician is who you're going to meet with to go over your history, your prior treatment cycles, and who's going to primarily do your diagnostic testing and review all those results with you. You will definitely see all three of the physicians throughout the process of IVF. We all do ultrasounds in the mornings, and depending upon who is available that day, you may definitely have an ultrasound or several ultrasounds performed by one of the other physicians. So you'll get to know all of us throughout the process. I didn't also put the nurses on here, but you will also have a specific nurse assigned to your, to be your nurse. And similarly, you'll meet all or many of the other nurses throughout the process, but you will have one primary nurse who will be the person who is going to be, your go-to person to answer questions about medications, order your medications, and all of those things. So you'll get to know about 6 different nurses that we have in the office as well. So in vitro fertilization, or IVF, is where egg and sperm meet outside of the body instead of meeting inside of the body. So the typical process of fertilization and conception inside the body is where one egg grows and develops. That egg is ovulated or released from the ovary. The egg is picked up by the fallopian tube, and sperm and egg meet inside the fallopian tube to create an embryo. This embryo then travels back down through the fallopian tube and implants inside the uterus to result in a pregnancy. With the process of IVF, in vitro means outside of the body, in vivo is inside. So in vitro fertilization is just meaning that this fertilization, instead of occurring inside the fallopian tube, this fertilization is occurring outside the body in the IVF laboratory. The fertilization could be occurring through traditional IVF, where sperm and egg meet, they're just placed close together in the dish inside the lab, or they could be done with IVF using ICSI, or intracytoplasmic sperm injection. And this is where one sperm is injected directly into the egg. And this is specifically designed for any issues with male fertility. So if there's a lower sperm count or a lower shape of the sperm, then ICSI is typically recommended. There are other reasons why ICSI may be recommended, but those are the 2 different types of fertilization in IVF. Reasons you may be considering doing IVF are if there's a blockage in the fallopian tubes, then sperm and egg cannot meet inside the fallopian tubes, and IVF is required for fertilization. Other reasons would be if there is a significant abnormality in the sperm count. We can assist with fertilization with a low sperm count using this process of ICSI, or intracytoplasmic sperm injection. And that can only be done through IVF, where the eggs are removed from the body so that we're able to directly inject that sperm into the egg. Unexplained infertility is also treated with IVF if IUI cycles or other treatments have been unsuccessful. Endometriosis can be treated with IVF. Diminished ovarian reserve is often recommended to do IVF. If you're preventing a genetic disorder, doing IVF with genetic testing of the embryos can help to prevent this genetic disorder from being passed on to future generations. IVF can also be done for fertility preservation, whether a couple is preserving their fertility or a woman is preserving her fertility by freezing her eggs. Eggs or embryos can be frozen through the process of IVF to preserve fertility for the future. About 1 to 2% of all babies in the United States are born via IVF. Outcomes from IVF pregnancies are tracked very closely, and there's no increase in any abnormalities in babies born from IVF. It used to be, I don't think as often now, but used to be thought of as a test tube baby. The eggs are in test tubes for a brief period of time during the egg retrieval, but the embryos are actually not cultured in a test tube, they're cultured in a dish. But as I said, sperm and eggs are meeting in the embryology lab, and the embryos are being cultured in the lab. So this is a process, this is an overview of the step-by-step process for IVF. So initially, you'll have a consultation with the physician, which will be a reproductive endocrinologist. And then that physician will do any baseline ultrasound and blood work or any diagnostic testing that's required prior to starting the cycle. Then there's typically some type of priming or synchronization of the follicles, some sort of lead into the stimulation.
There's pictures.
The stimulation is typically done at stimulation is typically done starting around the 3rd day of your period, but usually women are either taking birth control pills or estrogen tablets for a week or two leading into the start of the stimulation. The point of that is to help all the follicles grow and at a similar rate, so we can get as many eggs all to be at the same size, all at the same time. Then comes the process of stimulating the ovaries to produce multiple follicles. So every month your body is producing
every 2 days. Wow.
To stimulate one follicle to develop. In IVF, what we're trying to do is stimulate multiple follicles to develop. Ideally, as many follicles as we can get to develop within reason. So in some cases we're, careful, we are in all cases, but in some cases especially, we're careful to make sure not to overstimulate the patient, that we're not getting too many eggs, but ideally, trying to get as many eggs as possible within reason, to have multiple eggs that we're able to fertilize and culture and grow in the lab. The stimulation process is about 8 to 12 days in total. So every night during those 8 to 12 days, the woman is administering to herself or having a partner or a friend administer to her stimulation medications. During that process, the response of the ovaries is monitored with blood work and ultrasound. The ultrasound is measuring the growth of the follicles, and with the blood work, we're watching the rise of the estrogen and typically checking another hormone level or two to just monitor how the ovaries are responding. When as many follicles are in the mature range, and mature means a size of the follicle that is likely to have the ability to respond to the signal for ovulation. When we have as many mature follicles as possible, then we will do the trigger. And the trigger is the final injection that starts the process of ovulation. Now, we want the eggs to be able to be removed from the body to place in the embryology lab. So right before ovulation is about to occur, that's when we do the egg retrieval. The egg retrieval is done in the procedure area that's connected to the IVF laboratory, so that the eggs can be directly transferred from the procedure room into the IVF lab, and then the eggs can immediately be identified and then transferred to the incubator. After the retrieval, the eggs are fertilized, as I briefly mentioned before, either with traditional IVF or with ICSI, intracytoplasmic sperm injection. The embryos are cultured in the lab, typically until around day 5 or 6, although sometimes until day 3. So somewhere between days 3 through 6, the embryo will be transferred. In most cases, we would recommend transferring a single embryo. There are some cases where potentially more than one embryo would be recommended for transfer, but in most cases, we recommend a single embryo transfer. This all can be done in the same cycle. That's called a fresh embryo transfer, or the embryos could be frozen after they've been cultured, and then a delayed transfer or a frozen embryo transfer could be performed. After the embryo transfer, approximately 2 weeks later will be the pregnancy test. And then hopefully the news that we're all waiting for is that, we've been successful and able to start a family. So going through these step by step, the first part is baseline blood work. And this is looking at ovarian reserve. So women are born with all the eggs that we ever make. We don't make any new eggs after we get older. And I definitely don't mean this to be depressing at all. But even when we're at puberty, we've already lost half of our eggs. So we know that as we get older, the number of eggs we have remaining in our ovaries starts to go down. But that's instead of releasing one egg every cycle, what we're doing with IVF is trying to get as many follicles to grow in the cycle as possible. With the ovarian reserve testing, we're assessing how a woman would be likely to respond to the IVF stimulation medications and to choose a dose and protocol of medications that's most appropriate for that patient. So this ovarian reserve testing is blood work and ultrasound that's done on the 3rd day of the cycle. So on day 3 of your period, you'd come into the office for blood work. That is looking at the follicle stimulating hormone. This is looking how hard the brain is working to get the ovaries to stimulate. Looking at the estrogen level, AMH is another measurement of ovarian reserve, and then antral follicle count. Antral follicle count is looking at the ovaries by ultrasound and seeing how many small follicles that we can see start to develop. So these black circles here, this is an ultrasound picture of an ovary, and then these black circles here are each follicles. And these are all antral follicles, meaning small follicles that are present at the start of the cycle. Then there may be additional testing that's recommended prior to starting the cycle. Often a saline sonogram or hysterosalpingogram to look at the inside of the uterus. So we want there to be no roadblocks in the way of an embryo implanting. So for example, in this top picture here, you can see, I guess I'll start here. So this picture, the black area is where the saline is filling up the inside of the uterus. So this is a picture of a uterus by ultrasound, and this black area is the saline, and you can see the nice smooth contour to all the inside walls of the uterus. In this picture, you see something protruding into the inside of the uterus. And this is something where if we transferred an embryo and that embryo implanted right here on something like a fibroid or a polyp, that embryo would not be able to continue to develop the blood supply it needed. So if we see something like this on a saline sonogram, this fibroid or polyp we would remove prior to doing a transfer. An HSG is also a test that can diagnose tubal patency or tubal occlusion, and can also diagnose hydrosalpinges, which is a blocked and dilated tube, which is something that would also need to be treated prior to an IVF cycle. We'll also recommend a semen analysis, or we always recommend a semen analysis so that we can see, make sure that we'll be able to have enough sperm on the day of the egg retrieval, and whether we would be planning to do conventional or traditional IVF or the intracytoplasmic sperm injection or ICSI. In some cases, if there is no sperm in the ejaculate, the sperm may need to be obtained through a testicular biopsy or a biopsy of the epididymis. And this is something that's done would be performed by a reproductive urologist. And we coordinate the IVF cycle with the reproductive urologist, making sure that we have sperm available prior to starting the IVF cycle. There were a couple of questions that a patient had sent prior to this presentation or this cycle, and one question was about reproductive urologists, and there's no one particular reproductive urologist that you would need to work with if you're doing IVF with our office. There are certain urologists that are able to come into our office and perform procedures in our office or in the procedure in the surgery center that's adjacent to our office. But if a sperm extraction procedure needed to be performed somewhere else, as long as we had that frozen sperm in our office, in our lab, prior to the start of the cycle, we really could work. You really could work with any urologist. So the next part is the synchronization and then starting stimulation of the ovaries or ovarian stimulation. Sometimes this is called like stims. In social media groups, you may see this referred to as stims. So there are usually about 3 different medications. You may start with all 3 or just start with 2, but 2 to 3 different medications that are used to grow multiple follicles in the ovaries. And one of those medications is also to prevent premature ovulation. So we don't want your body to start to ovulate before we're ready to retrieve the eggs, and we have as many follicles ready as possible. So this is one of the, I think, the most daunting things through the IVF process. These medications will be ordered by the nurse, and then there's typically a mail order fertility pharmacy that would be delivering these medications to your house. And so you'll receive this big box of medications of all these different names and different needles, and it's very overwhelming in how these are all going to be mixed and administered. So I'm not going to go over in detail how you're going to mix and administer these medications, but I do have some of the examples just so we can, show them to you and you can get a little bit familiar with what they look like. So Follistim or Gonal F, almost all of the time, you'd be on one of these medications would be in your regimen. And these are common pens. So this is a Gonal F pen, and it has a cap, and then there is a needle that screws on. And I don't know if I brought any of the needles, but there's a needle that screws on to this, and there's a small window. And what you do is you twist the end to dial up the dose that you need to administer, and then you can inject this Gonal F solution directly into your other medications. Most of the time, one of the other medications you'd be using is called Menopur. And so the Menopur comes in a box like this. It has small powder vials and then small saline vials. And then you'll be using the liquid from the saline vial to inject into the powder vial, along with the Gonal F medication to mix all these together. And you typically will need multiple vials of the Menopur. So you'll have these all kind of lined up, and you'll mix all these together. The other medication that's often used is called either Cetrotide or Ganirelix. That comes in a small box like this that's in the refrigerator. And when you open it up, there's a syringe and needle, and then also another powder vial. And from this, most of the time, you're able to just remove the powder vial and not use the other part of it. So there are a number of resources that will help you through this process. Usually the first day, the first injection is really scary, and then it gets a lot easier as you go along. So this first link is a link to a video on our website that is from one of our nurses from the office going over how we recommend mixing the medications. And we usually tell you to use the pen medication, the Follistim or Gonal F, along in with your Menopur. If you prefer, you can administer these separately in two separate injections. They're also specific. There's also, instruction videos. The second link on this website, Freedom Med Teach, and you can look up each specific medication and they'll have instructions in there. This is the other type of FSH medication, the Follistim. So what these medications are, these are FSH that has been purified. And the Menopur is a combination of FSH and LH, and these are the hormones that tell your ovaries to produce a mature follicle. The Cetrotide, Ganirelix, and Lupron are the medications that stop your body from ovulating. The Ovidril or Novaril, these are the medications that signal the start of ovulation, and we will give you a specific time to administer this Ovidril or Novaril based upon the timing of your egg retrieval. So your nurse will give you specific handouts with this that have the doses that you are using, and again, links to these teaching videos. It's helpful to look at them once you have all your medications in front of you and you're ready to mix them. Keep that video up with you. So this is a Follistim pen, and this is showing the pen being directly injected. It's a subcutaneous injection. If you're doing your medications this way, you'd be doing two separate ones with the Follistim and then separately the Menopur, or the video that we have on our website will show you how to mix them together, so you just do one injection. This picture is an ultrasound image of a stimulated ovary. So each of these black circles here, these are follicles. And we're measuring each of those follicles every 2 days while you're coming in for the ultrasounds. And once as many of these follicles are between 15 and 24 millimeters approximately, then you would be ready for that Ovidril and for scheduling the retrieval. The egg retrieval process is performed with anesthesia. So you are asleep for that procedure, but breathing on your own. So there's no breathing tube, but you have IV sedation. This is administered in our procedure area, just across the hall from where all the ultrasounds and blood work are performed. So schematically, what the egg retrieval looks like is that these are the ovaries here, these yellow structures, and then these little blue circles are representing the follicles. This is a transvaginal ultrasound probe. Same thing that we use for all the monitoring appointments, but there's a needle and a needle guide, and then that needle is passed through the vagina directly into the ovary. And then there's gentle suction that removes the eggs and the fluid from the ovary into these tubes. Then the tubes are passed into the lab where the eggs are identified and then later fertilized. This is an ultrasound image of what it looks like. So these black circles, these are the follicles. And then this bright white line here, this is the needle that's going into each of the follicles. Women do typically have some discomfort and some bloating for typically 1 day to up to several days after the retrieval. It's typically able to be managed with over-the-counter medications, or we do also give prescription medications for pain if needed to help manage this. But most of the time, you only will just be need to take 1 day off of work the day of the retrieval. Most women are able to return to work the following day. Then the eggs are go into the embryology lab where they're identified, and then then fertilization occurs. Whether the sperm source will be either, if it's frozen sperm, it will be thawed. If it's a fresh sperm specimen, that will be also the partner will produce that the day of the retrieval. The sperm will be washed, and then sperm and eggs are placed together in the lab, or one sperm is injected directly into the egg by ICSI. This is a picture of the microscope, and this is the holding needle that holds the egg in place while the sperm's injected. So this is actually a picture of what it looks like in our lab while they're doing this. Then the embryos are grown in culture in dishes. And these are the incubators that we have in our office where every patient's embryos are kept. What the embryos look like over the course of the process, the day after egg retrieval is called day 1. And that's when the embryo has 2 pronuclei, or it's called a 2PN, meaning that it has fertilized. And this is the male nucleus. One of these is the male pronucleus, one of these is the female pronucleus. And then these are the 2 polar bodies. These are the 2, these have all the remainder of the chromosomes from the egg that were not needed for creating the embryo. As the embryo is growing and dividing, the embryologist will look at it again on day 3. Around day 3, there's typically around 6 to 8 cells, sometimes more, sometimes less. And then at this point, the embryo could be transferred or it can be continued on to grow in the lab until it forms a blastocyst. The blastocyst is a structure that forms around day 5 or 6, where there are cells on the outside of the embryo that form the placenta, called the trophectoderm cells, and then cells on the inside of the embryo that are the inner cell mass that form the baby. At this point in time, either day 3 or day 5, or if there's a frozen embryo transfer after the lining is prepped and they're ready for the transfer, the embryo transfer is performed. This is usually a fairly straightforward procedure. No anesthesia is needed for it, although some women will take Valium before the transfer just for anxiety and for relaxing the uterus. We do perform this procedure and ask you to have a full bladder when you come for this procedure. It helps because it is performed under ultrasound guidance, and that helps to see the catheter as it's being guided into the uterus. So this picture here, this is the uterus. And then this bright white line here is the embryo transfer catheter. And then the embryos will be placed right at the top of the uterus, about 1 centimeter or 1.5 centimeters from the top of the uterus. We, most of the time, almost always, I would say, recommend doing a single embryo transfer. So doing a blastocyst transfer of 1 fresh embryo, there's a 50% pregnancy rate and less than 1% risk of twins. If that's unsuccessful and you have more than 1 usable embryo, those a second embryo could be thawed and transferred in a frozen cycle. So there's a 66% chance of pregnancy in that case and less than 1% risk of twins. Whereas if you transfer 2 at once, the pregnancy rate is 60% and the risk of twins is 27%. So transferring 1 at a time does optimize the pregnancy rate of each embryo while reducing the risk of twins. If there is more than 1 usable embryo, more than 1 good quality embryo, the remaining embryos can be frozen. And they're not frozen in ice cubes, they're frozen and stored in liquid nitrogen in large tanks that are called dewars. And these dewars are kept in the office, and there's multiple backup systems in making sure that these embryos are always maintained at the correct temperature. One thing that can be done if you are not doing a fresh embryo transfer, but instead of doing the transfer in the same cycle, you decide to freeze on the embryos. You can, or pre-implantation genetic testing can be performed upon the embryos. There would be 2 reasons why your doctor may recommend pre-implantation genetic testing. One is that it could be screening for the number of chromosomes in the embryo. A common reason that embryos do not implant is because they have an extra or missing chromosome. This is one of the ways that happens as the embryos are dividing up their chromosomes. There should be half removed at each step of the way. So there would be 1 chromosome from mom and 1 chromosome from dad of each of the 46 chromosomes. If there is non-disjunction, meaning that the chromosomes didn't split up correctly, you can end up with an extra chromosome. So this is a trisomy in an embryo, where this chromosome, whichever chromosome it is, there's 2 from mom and 1 from dad. So this is an abnormal amount of genetic material, and this is unlikely to result in a live birth. There are some trisomies that do result in live births. One that you may know of is Down syndrome. So we can screen for this genetic disorder in the embryo by doing a biopsy of the embryo at the blastocyst stage. So this is what's called a trophectoderm biopsy, and this picture on the left shows the trophectoderm biopsy in process. So these outer cells, the trophectoderm cells of the embryo, a small portion of them can be removed from the embryo, usually around 3 to 5 cells. And then these attachments are dissected with the laser. These few cells that are removed from the embryo are frozen and sent to a genetic testing lab. It takes about 2 weeks for the results of that testing to come back. So all the embryos need to be frozen. Once we get the results back of the genetic testing, then the embryos can be warmed and transferred. We know that the rates of genetic abnormalities in the embryos goes up as women get older. In women that are 30, 35, it's about half. As women get older, the rate of abnormal embryos does go up. There are a couple reasons why it may be recommended not to do genetic testing of the embryos. There are some false positive and false negatives with this test and with all tests. It's a low risk, but it is a risk that we could get the wrong answer from the biopsy, and that actually these cells here that are in the inner cell mass are different than the ones that were biopsied. There's also a possibility that the embryo has mosaicism, meaning that there are some normal cells and some abnormal cells. And we could take a biopsy of some cells from over here in this area of the embryo and actually get an answer that doesn't really tell us what's the true result of the embryo. So it could tell us there are some cells that are abnormal, some cells that are normal. And what we really want to know is if the embryo itself is normal or not. So that's one possibility of genetic testing of the embryos that you would need to go over, prior to starting the cycle. You definitely want to make the decision with your physician and with your partner about whether or not to do preimplantation genetic testing. The other reason to do preimplantation genetic testing is if you carry a gene for a genetic disorder that you're trying to screen for in the embryos. That's something that the genetic testing lab would make specifically what are called probes, but basically a specific test looking for your genetic disorder. And that is called preimplantation genetic testing for monogenic disorders. But that is something that is one definite reason to do preimplantation genetic testing. So all of this, these previous slides, we're discussing IVF with using the woman's own eggs. There's another process of IVF using IVF with donor eggs. So if a woman has low ovarian reserve, is above an age where she is likely to be able to obtain genetically normal embryos from her own ovaries, or if she's had prior unsuccessful IVF cycles, it may be recommended to use eggs from an egg donor. This egg donor can be someone who is anonymous, or it can be someone that is a known person, a friend or a relative of the carrier of the pregnancy. So the eggs would be provided by the egg donor. The sperm would be provided by the partner or sperm, whatever the sperm source is. The embryo would be created and then transferred into the woman who is carrying the pregnancy. So this kind of leads me to the what we need for IVF is as an egg, a sperm, and a uterus. And IVF can be useful in families of all types. So same-sex couples, transgender couples, IVF is useful. We need to identify who's providing the eggs, who's providing the sperm, and then who's carrying the pregnancy. And then we use those components to create embryos and transfer the embryo to the woman who's carrying, whether that is one of the parents or if it's a gestational carrier for for a same-sex male couple or for a woman who's unable to carry her own child. So in the end, what we're hoping for is a successful pregnancy and live birth. And the process of IVF does involve lots of this stuff that's on the outside of the heart, lots of injections, lots of vials and syringes, but hopefully, all that science along with lots of love from the parents and providers, we're able to achieve a healthy and successful pregnancy and live birth. So I'm gonna now open it up to any questions. I did have a couple other questions that I had gotten earlier. So one of the first questions is, how long does it take to go through an IVF cycle from the initial consultation through the egg retrieval and transfer? And this can be a little bit varied. The initial consultation, once you have the initial consultation, it generally takes about a month to do all of the fertility testing and to do the synchronization of the follicles and then get you ready with the second menstrual period that you have after the consult to start the stimulation. If you're doing a fresh IVF cycle where you're doing stimulation and transfer in the same cycle, then that can all be done in the following month. So that would just be a 2-month process from the start of your first period after you meet with the physician to pregnancy test. If you're doing a frozen cycle, then that process is a little bit longer because there's the initial prep month of doing all the diagnostic testing, ordering the medication, synchronizing the follicles, then the retrieval cycle, and then waiting for the results while we're getting ready either to go directly into a frozen embryo transfer cycle or do additional testing of the uterus. There's one specific test called an endometrial receptivity analysis test, which is often recommended prior to doing a frozen embryo transfer. So in general, 2 months to maybe 3 or 4 months. One other add-on to this question was if there's a male factor, if a testicular biopsy needs to be coordinated, that all depends upon how long it takes for, to also coordinate things with the urologist and get the testicular aspiration scheduled. Once the sperm is obtained, then it's again, the 2 to 4 month process, whether you're doing a fresh cycle or a frozen cycle. So after the egg retrieval, why do we freeze embryos and not just eggs that could be fertilized at a later date? And there are a few reasons to that. The reason that we freeze embryos, initially the reason that we froze embryos is that embryos were much more successful at being frozen and thawed initially. Technology has now advanced that eggs can also be frozen and thawed successfully. So now it's in 2021, it's not so much that the eggs are unable to be frozen and thawed successfully. It's that if we just freeze eggs, we don't know how many usable good quality embryos are going to result from those eggs. So there's from every egg that is retrieved does not result in an embryo, and so it does take multiple eggs for a good quality embryo to result. So in general, we recommend going culturing for embryos and freezing embryos, because then we know how many embryos you have available. So from one IVF cycle, some couples don't have any usable embryos. Some couples have one usable embryo. Some couples are lucky enough to have multiple usable embryos. And in that case, we do recommend freezing those embryos. But we don't know until we have gotten the embryos through the eggs through fertilization and the embryos through culture and development, how many usable embryos there will be at the end. It does, for some couples result in a, ethical issue if you have more embryos frozen than what you're able to use or what you're planning to use to complete your family. In those cases, you can have the embryos, you can donate the embryos or have the embryos be able to be adopted by other couples that are unable to conceive with their own eggs or sperm. Or you could discuss with your physician deciding not to fertilize all of the eggs if you get more eggs than what you would like. If you're trying to, go for a goal of not having any additional embryos frozen once you've completed your family, you may decide to limit the number of eggs that are going to be fertilized. So that is all to say, why do we recommend typically freezing embryos instead of just freezing eggs? Now, freezing eggs is a useful option if a woman does not have a partner or if the sperm is unavailable for some reason at the day of the retrieval. Then eggs can be frozen, and then later those eggs can be warmed, fertilized, and embryos created. One other question is whether it's more difficult to get pregnant with male or female factor problems. It depends on the degree of the male or female problem and the and whether or not that's a simple problem, like if it's a normal sperm count but just low sperm morphology, that's often very easily able to be overcome with ICSI. If it's a female problem like tubal factor, that's often very easy to overcome by just getting the sperm and eggs outside of the body into the lab, since they're not able to meet in the tube. So it really does depend on what the problem is. So I don't think there's any easy answer there, but it just depends on the degree of the problem and what exactly the problem is. Is there a cost difference between the two different fertilization processes? Typically, yes, there is an additional cost to the ICSI procedure. ICSI is often recommended unless the couple has proven fertility together before, or if there's tubal factor, or if we know that the sperm count is normal, meaning that the shape of the sperm, all the sperm parameters are normal. In a lot of cases, ICSI is recommended. In probably the majority of IVF cycles, ICSI is recommended. But ICSI is often an additional cost. If you have insurance coverage, it will often depend on the semen analysis whether that ICSI procedure will be covered or not. But we often do recommend ICSI. The other next question is about supplements and diet and exercise. Along with that, someone had asked prior to the session about acupuncture. So supplements, not everyone needs to take supplements. There are supplements that have been studied and have some evidence that they can improve the egg quality. We know we cannot make new eggs once you're born. There's at least at this point in time no way to make new eggs. There are certainly research being looked into growing skin fibroblasts and trying to make those into eggs. At this point in time, there's no way to make new eggs. What we can try and do is improve the quality of those eggs. And one of the ways that has been looked at is taking some supplements that may improve the quality of the eggs. The one that we have found to have the most evidence and the best help for improving egg quality is called CoQ10, CoQ10. Typically 200 milligrams, either 2 to 3 times per day, depending upon whether this is being used empirically or whether it's being used for diminished ovarian reserve. As for diet and exercise, diet and exercise are definitely helpful to help you try and get to or as close to as possible an ideal body weight prior to the retrieval. Being overweight or obese can can decrease your body's absorption of the IVF medications. So it can decrease the number of eggs that you produce from the cycle. It also can make the retrieval technically difficult if the ovaries are difficult to get to through the egg retrieval. If they're So on diet and exercise, there's no one specific diet and no one or any particular exercise routine that has been shown to be the most helpful for fertility patients. What I always say is whatever diet is something that you're able to stick to. So for women who are overweight, especially for women with polycystic ovarian syndrome, being able to lose even 5 to 10% of your body weight, so even a modest amount like 10, 15 pounds of body weight can really improve your body's ability to ovulate naturally and your ability to absorb the medications. So that is really whatever's working for you. Women with PCOS, it is recommended to try and have a low carbohydrate diet. But aside from that, there's no one specific diet like, that's been shown to be better than another one. Same with exercise. Exercise is really, really beneficial for your physical health, your mental health, especially through a IVF process, which can be really stressful. So, but whatever type of exercise is something that you enjoy and can stick with. Acupuncture is one thing. Acupuncture is one thing that does go in conjunction with IVF and can be helpful as an adjunct to IVF. There are many fertility specific acupuncture providers. There is one in particular that does often come to our office. They are acupuncture in Michigan, and there's a few providers there that can even come into our office and do acupuncture both before and after the transfer. One additional question was about supplements for men. And there are supplements are recommended for men with sperm morphology issues. Those are extra antioxidant vitamins, vitamin C, vitamin E, zinc, CoQ10 are some of the ones, L-carnitine. They have these in combination vitamins. One of the ones that is a brand name that is usually fairly easy to obtain is something called Fertile Aid. And that is, at any pharmacy, GNC, or wellness store, or I think even at like Target. The egg retrieval process, I did have a question, and there's another question too about how physically demanding is the process, how painful is the process, what is the egg retrieval like, and it's different for all patients. A lot of the time, it depends upon the number of eggs that are retrieved. The more eggs that are retrieved, the more number of the larger the ovaries are, and usually the more physical symptoms that a woman has through her retrieval process and through her stimulation process. So there are complications from every procedure. There are possible complications. One of the most common complications from egg retrievals are ovarian hyperstimulation syndrome, or bleeding after retrieval. So those are two possibilities. The risks of that are low, but they are things that happen. They are things that we're able to, to provide supportive care and get you through that process. So I would say most women do recover well and are able to just take one day off of work and then return to work. Vitamin D is another supplement that has been shown to be helpful. Vitamin D, they don't know exactly the mechanism for it in fertility. It is a vitamin that's used or helpful for bone health, but it's not about the bone health in this situation. But vitamin D, women who have normal vitamin D levels or normal vitamin D stores do seem to have higher pregnancy rates. It's not yet been proven that if you supplement with vitamin D, that you will improve your pregnancy rate. But extrapolating from that, we often do recommend women to take an extra 2,000 units of vitamin D per day during the egg retrieval and during the transfer cycles. So, unless anyone has any other questions, I'd just like to thank everybody for joining in tonight. And if you have any other questions later on that you think of, you can reach out. Jean is available if you can send messages through social media or emails. And or we'll you can schedule a follow-up with your physician to go over any other questions that come up from this session. All right, thank you so much.